my name is Daniel Cook. I'm an anesthesiologist, and I was invited to Hillsborough County Fire and Rescue to talk about the AirQ Airway, which I invented. In particular, I just want to talk a little bit about the AirQ SP, which Hillsborough County Fire and Rescue have decided to use. It's a laryngeal mask device that has no inflation apparatus. What it has is a small little aperture underneath the cuff of the device that communicates between the cuff and the airway tube. So when you squeeze the bag and increase the pressure of the airway circuit, it increases the pressure in the cuff, tightens up the seal, and allows you to ventilate the patient. But in between breaths, it lowers the pressure and decreases the pressure in the throat, which theoretically should improve complication rates. The reason that's important is to decrease the pressure in the cuff and change it from a high constant pressure to an intermittent pulsatile pressure, which should diminish the negative flow pressures from high constant pressure in the throat and allow an increased flow into the brain. Now, I'd like to introduce you a little bit to some of the features that make the AirQ easy to use. One, it has a very serpentine sort of shape, which allows it to go into the posterior pharynx and stay there very easily. The second thing is the large bowl, which allows me to trap the larynx inside the tip of the device and center the larynx to the outlet of the tube. The epiglottis elevator ramp, which elevates the epiglottis and holds the epiglottis up and then optimizes the airway conduit by stretching open the airway. And this little ramp that allows me to adjust the trajectory of the endotracheal tube so it'll pass easily within the larynx during intubation. I think we should just go over on how I use the device to make it easy for you to use in the field.
Inserting the AirQ is really easy. After removing it from the package, you need to lubricate either side of it with a water-soluble gel. And in doing so, it will slide down very easy. Your target when you look into your patient's airway is the posterior oropharynx. So I would look at, for instance, the uvula as a target. If you push it along the hard palate, the device can fold back on itself, so you don't want to follow the contour of the hard palate. Instead, aim right for the back of the airway, past the uvula, and allow the device to naturally follow the human anatomy and seat itself. It's very easy. As you can see here, Dr. Cook inserts the AirQ with relative ease, following the trajectory I talked about, aiming at the uvula, the posterior oropharynx, using the top and sliding the AirQ into its seated position where you have a safe and secure airway. Remember, with the AirQ, your gold standard is not intubation, the gold standard is ventilation. And that's the whole thing that we are trying to achieve by the rollout of this product, better ventilatory practices.
At this point, you should be able to move air very simply and very easily with your patient. Keep in mind that the epiglottis elevator is holding the epiglottis upward and maximizing the conduit in its open position, so you should be able to move air very well at this point. And that's really all there is to it as far as ventilating a patient. The AirQ is a really easy way to ventilate people, but it's also a rescue device in that you can put endotracheal tubes in it really easily. So to intubate through an AirQ, it's real simple. You just grab the AirQ, you wiggle the connector back and forth until you get it out. You take a standard endotracheal tube, roll it into a ball a little bit, you suck all the air out, you put a little lubrication right on the airway, and actually I squirt it right down into the tube a little bit when I get a chance. Then you hold it and you run it up and down to lubricate the endotracheal tube and the airway a little bit. There's a couple tricks involved here. I like to put the head in extension. If you put the head in extension, the endotracheal tube goes in more frequently. I like to do what we call the burp maneuver, which stands for backward, upward, right pressure. But simply all you do is reach around with your left hand, you push down on the thyroid, and then you push it over to the right a little bit, and then just take your endotracheal tube and just slide it forward. Typically, that's all you need to do. If you do those maneuvers correctly, you can expect about an 80% intubation rate on one pass of a standard endotracheal tube. It's not always necessary to intubate your patients through an AirQ. It's a great ventilatory device, and it would be just as easy to take them straight into the emergency room and let the emergency room people do the intubation. What's nice about the AirQ is it allows the transition from the emergency people in the field to the emergency people in the emergency room to put an endotracheal tube in the patient without losing the ability to ventilate the patient. This transition between a rescue device and an endotracheal tube is often very difficult with other devices with AirQ. It's a snap, and you can do it all without manipulating the head or without taking the air device out at all. Intubated in the field, you can easily just attach everything together here in the patient and ventilate the patient. But you probably don't have to take the AirQ out. You can just leave both devices in until you hit the emergency room and let them deal with the removal of the AirQ. There's a device called the removal stylet that makes it really easy to take the AirQ out and leave the endotracheal tube in, but I think in as far as the emergency rig situation, that's something that you just don't need to bother with. In the end, I can tell you that if you use AirQ and you get used to AirQ SP, it will be an easy device to use. It will ventilate your patient and you will save lives. I think one thing that we lose track of is how long it takes to intubate patients. Even the most experienced people lose track of time, and it can take several minutes before you know it and you haven't even ventilated your patient. What I think is really important about the concept of intubating through a device like the AirQ is that we can actually ventilate right up to and during the intubation procedure, so that we have more time because we're ventilating the patient during the intubation and we don't lose track of time and make our patients apneic. Remember, all the bad things happen when patients are apneic. That's when they get acidotic, that's when they get hypoxic, and that's when their heart rate is down and they go into arrest. So as long as you're moving air, you're safe. And that.
Would like to thank Dr. Cook and the folks at AirQ for coming by HCFR for our Train the Trainer and for giving us some insight into this great new device. Thanks to all of you for tuning in, and remember, every day is a training day.